Good morning. So I am so honored to be invited to present on this topic. It's very complex, as you can imagine, and a heavy lift. So I'm Kimlin Ashing at City of Hope, and I have nothing to disclose, but open to changing that after this meeting, if we talk to any of the funders here. So I hope this slide becomes evident as I go through the talk, because it's so important that each tile represents a component of us as a community. And I really want you to join with me as I walk us through the very community, population, advocate, and patient lens of cancer, as I link that to the very complex and multifaceted context of disparities and equity. So just a little bit about City of Hope, because I'm very proud to be part of the City of Hope family. We're now a national City of Hope with cancer centers, not only in Southern California, but also in Atlanta, Chicago, and Arizona. So we are now in the top 10 of cancer centers in the US and still #1 in the West. So this is our catchment area, our community that we serve in the Duarte campus where I work. And so we see that we're very, very diverse. So we cover the 4 counties of Southern California. We serve a population that's almost 18 million, 45% of all of California, and very diverse in terms of our ethnic makeup, being very heavily minority dense. So we are a very diverse and robust but small group within City of Hope, CCARE, our Center of Community Alliance for Research and Education, where we join with clinicians, advocates, policymakers to really address health equity and health disparities. And we really believe that our constituents really are the ones that we serve. So we're like a startup within City of Hope. So the groups that we engage are really broad and very multi-sectorial. Policymakers, like I said, health plans come to our table, patients, of course, advocates, community members, schools, and I'll show you a program that we have in the school district, as well as community clinics and hospitals, and certainly faith-based organizations and professional organizations, including nursing associations, which sometimes gets excluded as we talk mostly with clinicians and physicians, but our nurses have been very, very important in the work that we do. So want to kind of share some nomenclature and languaging that we use in the work that we do, and hope that you become familiar with this, is that social determinants of health that you may have heard of, and I like to think of it more as societal determinants of health, because I think that brings in more of a responsibility in terms of societal context, whereas social context tends to kind of butter it up and smooth it up a little bit. And so these are conditions where people work, live, play, pray, function on a day-to-day basis, and that's the context of how they live. These are the root causes of much of the health inequity and disparities that we see, and these are based on laws and policies that existed not too long ago, but policies that still exist that perpetuate these disparities and segregation. And when it comes to health outcomes broadly on a population level, that our zip code may be more important than our genetic code. And so the map that you see there really represents the redlining. How many of you have heard of redlining? Several of you. And these are policies that were developed with a partnership between the government and the real estate industry to redline basically neighborhoods. Any guess? redlining consisted of communities that were, guess, minority dense. So these communities were slated for degradation because they were not given funding for home improvements, for home loans, and the green areas are the communities that were more homogeneous, white. And these were slated for development and home improvements. And you see that, especially in LA, where I've lived for almost 35 years, that this still persists. And that these communities have long-term consequences of poorer health outcomes, lower educational attainment, and greater disease burden, including cancer. So even when these communities may have lower incidence, they have higher mortality and burden. So this just, represents this in a graphic form. And when we look at a population level, we talk a lot about gene and gene response in terms of a treatment, and that's certainly critically important. But backing up and looking at the whole cancer context in terms of prevention and risk reduction, we see that genes and biology really account for 10% of the risk. And really all of these other determinants that can be modifiable really accounts for 80 to 90% of the risk, including the societal determinants of health that I mentioned. And these inform healthcare, where hospitals, where cancer centers are based, and the population that we serve in these cancer centers in these specialized care contexts, but also health behaviors, as I hope I will share more. So again, just to reiterate, so zip code or a ZNA are those economic factors, physical environment, green spaces, access to healthy food at low cost, and those influence health behaviors. The CNA is the clinical context, right? Access to care, affordability, the quality of care. And then the less modifiable context, really, again, which we've talked much about in this meeting, it's really the biology and genetics. And we know that that does exist. For example, BRCA mutation, high incident populations, history of, say, sickle cell, higher incident populations. So financial toxicity, and I think one of the speakers mentioned this, these are pre-existing conditions. So sometimes we think of, financial toxicity post-cancer diagnosis, but as a population scientist and trained in psychology, we're really looking at financial toxicity as a pre-existing condition. And folks who are, poor or lower socioeconomically resourced often live in food deserts, often have dedicated tobacco vape shops that are in higher density. So for example, we did an analysis, a spatial analysis of part of my community. So we compared SPA 3, which is where City of Hope is based, and there's a lovely community there called San Marino, and there were no dedicated tobacco shop. So it may be sold in the, the grocery stores or maybe in the gas station, but not one single dedicated tobacco vape shop. In SPAR 1, that's the Antelope Valley, that's a community of high burden, there were high density of dedicated tobacco vape shops. So almost every mile, you'd find a dedicated tobacco vape shop. And these communities are minority dense. And interestingly enough, in terms of target marketing, in some of these communities, unbelievable that the tobacco products are slightly less expensive in those communities. So there is a lot of work that we can do in terms of protecting our community and being mindful of our community and the population we serve and the context that they live in as we talk about cancer care and access to studies. So less likely to have medical facilities, as I mentioned, where our comprehensive cancer centers are located and the populations we serve. Also, lower education, lower access to higher paying jobs, less time off for work. So we might find that some of these challenges in terms of treatment adherence and being able to participate in a study where there are multiple visits, right? If you don't have time off from work, that may not be something that you would want to do because you need to feed your family and provide shelter. So again, the quality of care in terms of, we know that those who are treated in, and I'm not knocking community settings because we know that's where most of the population are treated, but those who are treated at a comprehensive cancer center, when you come to a place like City of Hope for breast cancer, you're seeing a radiologist, all of the professionals that you see within our cancer centers, they specialize in just breast cancer. That's what you're going to see. At a community setting, you may have a professional, but they may see multiple cancers, and so you're not getting the kind of specialized care that one could benefit from. So here are some of the statistics in terms of incidence. The first bar is Asian, American Indian, Native American, then Asian Pacific Islander, which we do lump, and I do advocate for disaggregation of that data because the Pacific Islander groups have poorer outcomes and higher incidence for certain cancers, including breast cancer. The Hispanic Latinx population, then African American Black, and then the non-Hispanic white. And as you see, greater incidence for many of the cancers, and we highlight prostate cancer because that has the greatest incidence burden for our African Americans. Similarly, unfortunately, mortality, we have higher mortality for African Americans for prostate cancer, but we see mortality disparities even greater across the different cancer sites. So cancer care in California. So almost 190,000 Californians are diagnosed each year. It's the second leading cause of death in California. And again, those receiving care at specialized centers have a 53% reduced mortality, and less than half of California patients receive the standard of care. So some of the programs that we're doing, looking broadly at the context of cancer and cancer prevention, and starting early in community advocacy, which is where I live and really work. And so we have our Youth Nutrition Leadership Program that has been going on for many years within City of Hope, and we target students who are in lower resource communities to work with their school districts to educate about food as medicine, food in terms of the risk for cancer, and we create champions, right, within the schools. And they produce these infographics that you see. These infographics are now shared within the school community. It's also shared within the larger community. One school set of trainees, they actually wrote an article for the local newspaper. And they're influencing like the Parks and Recreation Department in terms of what they serve in terms of the after-school programs, having more nutritional, more plant-based foods. And we teach them also about shopping, like, you know, at the grocery. You see these canned foods and junk foods at the front. These are target marketing, so we educate them on how to shop well and how to find, we call it eating right when the budget's tight, to pick fruits and vegetables that are in season that would be lower cost and higher nutritive value. We also have evidence-based screening strategies that we implement, and so proud that we have just launched late last year a mobile unit. It took us a while to do that at City of Hope, but it's as comprehensive as it can be. So there's a mammography unit. We offer cervical cancer screening and blood-based testing for colorectal cancer, and do referrals for lung cancer screening as well. We had a program funded by HRSA to our FQHC, Federally Qualified Health Clinic, because that's where a lot of the cancer screening will happen, right? The first evidence of abnormalities happens in local federally qualified health clinics. And so that program was called AXIS. And we really, take this unit to the community so that we're reducing the barriers of, say, transportation and multiple appointments for the screenings. So all of these screenings that we offer could happen in one appointment. And we're working with both clinic and provider engagement in terms of training the FQHC's clinicians on, screening guidelines and reminding them updates of screenings. Colorectal cancer is now age 45, so reminding folks that even when people have coverage, they're not always accessing the screening because sometimes the clinicians forget they're dealing with the more chronic disease like diabetes or hypertension, and may omit sometimes the cancer screening that patients are eligible for. So we're trying to eliminate the barrier of multiple appointments and having all of these screenings in one appointment. So we also create infographics that's co-designed by the community partners that address screening guidelines. We have colorectal cancer, which we see, we have trends in terms of younger age of diagnosis. So we really want to educate people as early as 45. And if you have a family history, then you need to get screened earlier. We have programs targeted to all of our major ethnic groups. We translate these in many languages in terms of Chinese. We have it in Spanish, as well as Korean as well, because we have a fairly large Korean population in Southern California. We hear little about tobacco cessation and control, even though tobacco use and exposure is related to so many cancers. And even for those who are diagnosed with cancer, we've found in our studies that, remember I told you about the Antelope Valley region, that's a population of high burden. Well, we found that our cancer patients in that region continue to smoke after a cancer diagnosis, 10%. That's almost the population level of tobacco use. In communities where there is less diversity and more economic wealth, those patients smoke maybe at 5%, so half. And so we focus on the community. We engage with the FQHCs, again, the clinic partners, to educate the clinicians so that everyone who comes into the clinic hopefully will have a screen for tobacco use and a referral for tobacco cessation. And at City of Hope, 90-something% of our patients get screened and do have a follow-up. And so we have programs that target sort of the low-hanging fruit. So the pre-op patients tend to be more willing to participate in tobacco cessation because sometimes they will not schedule their surgery unless they quit. And so we have a variety of services that we offer, especially at that opportune time, so that patients hopefully will quit. So one of the things that I'm so very proud of, City of Hope led this policy effort. And how many of you have heard of SB 987, the California Cancer Care Equity Act? So this is an act that was signed into law in January 2 years ago by Governor Newsom. It allows for those who are covered by Medi-Cal, so it really is a game changer for Medi-Cal patients, to be able to access care at comprehensive cancer centers like City of Hope. It's not a flawless law. There's still a lot of work to be done. As you know, healthcare is very, very complex in this country. And so it got watered down. But again, it's very community engaged. We worked with lots of partners, including ACS, to get this law into the books. And I'll go through this very quickly, but you will have these slides. So this gives some of the context of the laws and some of the limits and barriers. But the opportunity is that any patient can petition to their health care plan to be able to access care at a comprehensive cancer center. And if you contact us, we have a sample letter that they can use with their health plan. So I'll go through this. You can look at these, but it gives you some of the context of the law. But I want to end quickly with focusing on clinical studies and biospecimen studies, which we know that all of the therapies that we discuss here is really based on this. But yet we have a challenge in terms of who has access to clinical studies and, the population that benefit the most. So we know all of the benefits of clinical studies, right? Cutting-edge treatment, not only in terms of therapies, but certainly diagnostic, prevention, quality of life. So some of the work that I do is really behavioral and quality of life, so non-therapeutic trials or studies. You get the most comprehensive care. You get tested all the time, and so you're really getting the best care possible. You get personalized care and increased monitoring. And you get to contribute to science and the future of medicine. So there's a lot of good reasons to participate. And many of the folks in the community that I talk to, when I say this, they want to, but there are challenges and barriers. So this is a demographic of who participates in clinical studies across the US. So we have the census at the top with the population. We have the general clinical studies, the second line, and then clinical studies or clinical trials. So we see disparities, right, in terms of who participate in clinical studies. We're doing a little bit better with the Asian population, but really poorly with Hispanic, Latinx, and our African American. And we don't even capture our indigenous population very well. In fact, they're often mislabeled in the cancer registry as white, because some of that is just based on how we classify people by phenotypic appearance. At City of Hope, we're really trying to do better, but there's work to be done there as well. So what we know is that communities are the pillars of health change in their settings, that they can influence research by telling us what's important to those communities. How can we reach diverse communities? They can influence practice in healthcare because their constituents trust their words sometimes more than they do the clinicians and the researchers. They help us increase public trust, and we know that's so important, especially in these times and days in our political context, that public trust in the work that we do is so, so very important. And our funding is going to be based on that public trust. We need our community advocates now more than ever, and we recognize that, and we're honoring that. And policy implications. We would not be able to get SB 987 passed without the work of community and advocacy organization. For example, the California Black Health Network was really, really important at testimonials before California Congress, and certainly funding. And these are some of the areas where community advocacy has made a big impact. So the DoD funding is really based on community advocates going to Congress. CDC, the Breast and Cervical Cancer Early Detection Program, PRCORI, many of these, our tobacco research program that we have in California, it's about advocacy, and certainly SB 987. So we have developed this program called the Community Scientist Advocate Program, where we train community advocates. These are trusted community advocates already doing amazing work in the community and just leveraging that authority and trustworthiness that they have in the community and leveraging that to advance their science communication and their ability to talk about clinical studies and gain the confidence that clinical studies really is for all of us. And with the amazing support that we have from Gilead, actually, that has supported this program, we have now trained over 100 community scientist advocates. We ask a lot of them, and so we are also supporting them in amplifying their voice in the community so that they're changing the nomenclature around clinical studies. So we're not using trials. When have we ever thought of trials as a positive thing? in society. Never, ever. But we continue to persist in using some of these nomenclatures. And so we talk about clinical studies. People are much more open. Plus, it translates better in other languages as well, including Spanish. And so we offer, 6 modules. We do a nice graduation that's virtual now so that we can accommodate more people and eliminate the barrier of transportation. We put on little virtual hats on them, on their pictures, and they get a certificate. And we support them in the community advocacy work that they're doing to change the attitude, awareness, and benefits. So it's really about activating the community. And there are many levels of changing who participates in clinical studies. Certainly, the burden really is upon the industry and a healthcare context. But we also believe that raising the voice of community can also be an important game changer and practice changer. If a person comes in and asks, is there a clinical study available for me? You might be a little bit surprised, but then it will make you think about, how do I talk to this person now about a clinical study, or educate them about, cancer.org or clinicaltrials.gov, so that they can look and really see that clinical studies is not only for sick people either. There are broad clinical studies, other prevention studies on all kinds of illnesses, not only cancer, but certainly important in the oncology arena. And then I just want to share this slide because we talk about this earlier on. And so inequity is, not only, it's just falling into their mouths. And the tree is bending towards this little kid. And this kid is like, oh, there are very few apples in his orchard, right? And then equity, where we are, giving this kid a little bit taller ladder to reach, but the apples haven't changed. There's still more on this side. And here, where we're really talking about justice, where the tree doesn't bend in anybody's favor. And I think approaching our patients and clinical studies and invitation to clinical studies from the context of justice and looking at how we incorporate that context that I talked about earlier, so very important. And I want to thank you for your time and attention, and again, end with this slide. And see, this is very important to vote. So vote, and we advocate this for our community partners. Vote in local elections, in state elections, federal elections. Really, your voice is so important, and it does impact the funding that goes into research and who benefits. So thank you so much for your time.
Thank you so much, Dr. Ashing. I don't know if there's a question in the audience before we head to the next session before lunch. Okay. Thank you. All right, so now